The Rosalind Carter Institute for Caregiving has devoted many years to doing caregiver supports. And we've also been very involved with how evidence-based programs have moved forward. We were very fortunate to receive funding from the Administration on Aging to examine these and implement, I should say, these two evidence-based programs I want to share with you about today. I do want to recognize, I'm presenting about REACH and Cleveland Managed Care. We do have some of the original REACH investigators in the audience. We have Alan Stevens and Laura Gitlin, and we also have one of the original investigators with Cleveland Managed Care, David Bass. And I'll move on. I want to share with you what our experiences have been. I'll begin with REACH. REACH is a 6-month program that targets caregivers that are living with Alzheimer's disease. As long as they say that they have stress with caregiving, they don't have to have a formal diagnosis. There is a risk assessment that tailors the intervention to the individual caregiver concerns. They look at many areas. They look at health. They look at education about the disease. They look at safety in the home, problematic behaviors, depression. It's an empowerment program. It's an incredibly empowering to the dementia caregiver to be able to problem solve and think through and be able to enhance their abilities to deal with these problems. The delivery of this particular program involves 12 sessions, 9 in-home is the way we carried it out, 3 telephone sessions. Telephone support group is done separately. So you've got an interventionist that goes into the home, and then you have an independent third party doing the telephone support group is how we carried ours out. It is very flexible on the delivery. Let me share with you some updates about this. Our particular Georgia REACH was modeled after REACH VA. REACH VA took the original REACH materials and fully manualized all of them, scripted them out. The scripts are not read. The scripts are just guidelines, so when you get in the home, you know how to move forward. What they've done now, and they just recently released this, and they've shared it with us as well, is they've gone to 4 visits and to see whether or not the intervention is going to be able to achieve significant outcomes within 4 visits. I want to share this with you because of flexible delivery. There is also another site that's looking at totally telephonic REACH, so it looks like it's very adaptable for delivery, so I mentioned that for that purpose. The target population for this intervention are the stressed caregivers. For the ones that we visited, they needed to say that they were stressed. They needed to share that they rated their stress on a scale of 1 to 10 as greater than 5. And they either needed to live in the home with a caregiver or provide at least 4 hours a day of care, such as delivery of meals and preparation of meals. Personnel. This is what's kind of incredible about this intervention is the interventionists really just need those wonderful interpersonal skills when they go into the home. They have to have a high school education. All of ours had at least some college education, but that wasn't the main focus when we did all of our interviews. And we carefully screen them. I think your interventionist, the person that you hire there is really your face of your intervention in the home, so your selection needs to be very careful. We did a 2-tier interview. We had different panels look at them, and they also, we utilized, REACH has a certification process so that there is mastery of demonstration of skills there. And believe it or not, we had hired one person that went through the training process but didn't make it through the certification process, and we let them go. They just didn't have the skill set to take it forward. So that's an incredible, I think, a lesson learned there. We're always interested about cost. This is a cost analysis, not a cost effectiveness. When you're looking at agency implementation, REACH VA was able to implement it at a cost of about $5 per day. Our preliminary analysis is about $7 per day. And the difference, I think, is we're in a rural setting. We drove about 110 miles sometimes to go one way to visit in the home. And that really does add to your cost. But sometimes you're the only people that some of the caregivers have seen in a long time. In fact, when they were looking at some of our, when we were looking at some of our data, what we found that they really do enjoy that social interaction in the rural settings. They didn't value the telephone support process part of this as much as they did that face-to-face. So an agency could implement anywhere and give them a cost analysis of about $5 to $7 per day. Outcomes we're seeing, like many of the other evidence-based interventions, decreased burden and depression, increased caregiver health, increased their confidence to be able to manage those problem behaviors, an increased care environment, and as far as plans to institutionalize, they are having less conversations about institutionalization within the family. So that's significant. As far as highlights, this REACH has been implemented successfully in very diverse settings. I've already mentioned the VA. Our setting was the Area Agency on Aging and Senior Services. Primary care clinics have used this, as well as acute care hospitals. It has been translated into Spanish in the Curador program, and that was very successful. They got buy-in from the area there with using the promotoras as their entry into that population. I've already mentioned that it has written training and a caregiving notebook manuals. So not only do you have a fantastic interventionist training manual coupled with their field manual, but you also have a caregiver notebook, which is has divisions in it, addresses the most common problems encountered by these caregivers, and it's left in the home. And every time you go back in there for that intervention, you say, bring out your caregiver notebook. Based on the risk priority, you know, we identified together, you're working with that caregiver. We've identified together that this is one of your main concerns. So turn to page so-and-so in this notebook, and that's how you progress with that. I think it's, the last note in here says tremendous cost savings compared to institutionalization. When I'm looking at $5 a day to implement it, that's $150 per month. And I'm a geriatric nurse, so I've worked in the long-term care setting for quite a while. And I can tell you that an average in our area is like $5,000 a month in institutionalization. So every month we keep them at home and we let them age in place and love them in that place. Then we're saving money and we're saving emotional impact on that family. We have had our set of challenges in implementing Georgia REACH. Rurally, a lot of it was marketing and recruitment. I can share with you, we did hire a program assistant in the beginning, and that was going to be her job, was outreach. Well, it turned out that really is a much bigger job for just that one person. I see a lot of heads nodding. What we found out that we could, depending on the caseload of our interventionists, they were able to take on that role and help with that marketing and recruitment, and that really turned out more people for us. You're dealing with geographical distances, long distances, multiple counties, and trying to reach them through a number of ways, from faith-based to advertisements in the paper. Really what we found was the best was our senior services, and our agencies on aging were the best area for recruitment. I want to finish with talking about REACH, saying that we hope that the recommendations that we would say is to expand the availability of this intervention to more caregivers through dementia-capable systems in all of the states in the United States, maybe through their area agencies on aging and their senior services nationally. Also, I think that if we include them into the employee assistance programs in businesses, I think you'd have an uptake there if that was a benefit, not something that they necessarily had to pay out for, but we should consider that as a mechanism that if it was a benefit for an employee, that might be very strong, and I think they would have less days lost in the workplace, so it would benefit their employers as well as the employee. And the last recommendation, and this is both the same recommendations we're making for both of these evidence-based programs, we do need a national demonstration to determine that cost effectiveness, not a cost analysis, but the effectiveness. But to do that, you also need to, when you're thinking about your informed consent, write it in your informed consent that you're going to gather those Medicare numbers and gather those numbers. because other than that, you won't have the data to utilize when you're finished. Okay, let me move on to an equally important and incredible evidence-based program, Cleveland Managed Care. It is a 12-month telephonic program with computer support targeting the caregivers and the care receivers. So the entire dyad is affected here that are living with Alzheimer's. Both of these interventions can be used with early dementia as well as moderate to severe stages. There is a risk assessment or inventory with this evidence-based program as well, and it is individualized because both of them tailor then the intervention to the needs and the concerns of that family. It is an empowerment program as well, looking at the involvement of the family and friends, the education, the resources in the community, and how you connect to those, but empowering them to do it. In other words, don't give them the fish, but teach them how to fish and move it forward. In delivery, it's more intense as you begin with the telephone or email contacts every 2 weeks for the first 2 months, once per month during the months 3 through 6, and every 3 months beginning on month 7 and through the remainder of the service. Again, the population is all caregivers that say they are stressed. They do not have to have a formal diagnosis. The personnel that are hired to, the interventionists that are on the telephone with all of these care receivers and caregivers, or care consultants is what we call them. They have a college degree in nursing or social work or in a related field. That background really does help them as they reach out and know the resources that are available in their areas. As far as certification process, they don't have a certification process yet, but they do go through an intensive training of a minimum of 16 hours, so they are well trained. This is a very when you learn a cost analysis, this program we're looking at $50 a month or about $1.60 per day if an agency wanted to implement. So it's very doable as far as money. Outcomes, again, an improved care environment, reduced hospital admissions, delayed nursing home placement, fewer emergency room visits, reduced caregiver depression, stress, and burnout, reduced relationship strains, decreased embarrassment and isolation, and improved access to information. This program did not have any challenges in recruitment. Our goal was 450 for the study. We're in year 2, and we've already exceeded that. We have had no problems with recruitment in this particular program. And I have some ideas on why that probably is. And I can share that as we get on to that part of the discussion. The only challenge that we did find was some of the care consultants, because this was run through area agencies on aging. We have 3 different sites, is that some of them did not have the background in Alzheimer's and dementia, which we went in with education and supplied that. Some highlights, it was implemented in 3 area agencies on aging. The gateway referral process accounted for probably about 2/3 of our recruitment, but we also took some active recruitment in those communities, about 1/3, but we still had a great, and still do, have a great steady stream. Clients were served in-home. They could be served long distance, and they could be friends, and it could be care receivers and or caregivers. Caseload. Caseload, you think that's a lot on a caseload. Our caseload for our care consultants has ranged from 71 to 150. And the ones with 150, even though that seems like a high number, the quality does not seem to have been sacrificed at all. They're still, they're monitoring that and looking at that, and still it's a great delivery of service. This particular program, some people might, it is a 12-month, but they might say, well, I've gotten all I can get out of it right now, so it could be tailored to a shorter time, like a 6 or 9-month program. It does have a computerized protocol, so when questions are asked, certain triggers come out, and so you move like an algorithm to another area. And I think that's one of the great highlights of this program. The recommendations are the same as with REACH, except for let's expand it to more caregiving dyads, not just care receivers. All right? that completes my presentation. Thank you.